All right, welcome to our live stream. We are performing a procedure called a rhizotomy in a patient's lumbar spine. He has back pain coming from his facet joints, and the facet joints that are hurting him are specifically the L4-5, L5-S1 on both sides, and we are going to be treating them right now with what's called a rhizotomy, specifically a Deuk plasma rhizotomy, which is a new kind of rhizotomy we're doing that is more permanent and gives more permanent pain relief. Wipe. So we've been doing these now for about a year, and we've not had anybody where it didn't work. So we've had some great success, and we expect this patient to have a great result as well. Shot. I'm targeting the junction of the transverse process, superior facet, which is right where the arrow is. Yep, it's perfect. And once I get to this spot, I'm creating a burn right along the transverse process. Shot. And that's what a rhizotomy is. It's a burn. Shot. Shot. Every time I say shot, what I'm actually doing is taking a picture with my x-ray machine. Shot. That feels like facet right there. Shot. That's it right there, Jordan?
Yes, sir.
Shot. And you can see the transverse process on the picture there. Shot. That's really nice right there. The problem is, of course, with the patient being awake, his muscles are contracting. He has a lot of muscles. So I think that's good. We've done one nerve. We're going to go to the second. And the nerve we're trying to cut through is called the medial branch of the dorsal ramus. This happens to be a small nerve that comes out of the spine, right where the nerve root comes out, and it goes to the facet joint. And its whole purpose is to basically give feeling to the facet joint. And if you have pain in your facet joint, well, then you're actually going to feel the pain because that nerve is there. So doctors figured out a long time ago that you could really actually destroy that nerve and eliminate a lot of people's back pain, at least the people that have pain from their facet joint. Now, if you have disc pain, it's a different story. You're not going to get rid of disc pain with this procedure, because disc pain comes from the disc, and you have to operate on the actual disc to get rid of disc pain. All right, shot. Once again, I need to find the junction of the transverse process and the superior facet, which is right here. And our goal is to get rid of that bad nerve, the pain nerve. Shot. It's pretty much right where I'm at, right, Jordan?
Yes, sir.
I couldn't get a better place than this. I feel the superior facet, I feel the transverse process. I actually feel the mammillary process along the TP. All right, 2 down, 1 more to go. We're on the left side currently. We'll be going to the right side soon. I'm trying to do everything through one little incision. And hopefully we can. It's too low. Shot. 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 How's blood pressure? Yeah. Uh-huh. Why not? Yeah, why not? Oh, I see, I see. So I would make sure he's awake and asking for it.
Okay, he's definitely awake and asking for it, but I think it's when
He starts to fall asleep and drift, but when he wakes up, he's gonna.
Well, what's his last dose of IV Tylenol? This will stop it.
That was at 5, or 3, or 150, 352.
That's too soon. He has to wait on it. When he goes back to wherever he's gonna start.
Usually takes oxy.
No, when he goes back.
Whoa, 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 whoa.
So now?
Usually oxy?
Yes, 3 times a day. 3 times.
And how many doses has he had?
2.
How many doses has he had?
Of oxy, he
Yeah.
only had this one this morning before his procedure.
Thought he had 2.
Well, that's part of the problem. He's going through withdrawals, guys. We need to get him the oxy, but he has to be awake.
Dilaudid and
Yeah, Valium and Valium.
withdrawals are so low on the list for me right now with him. Absolutely not.
No, that's refractory pain from withdrawal. That's what he has. Yeah, of course. If you stop taking your narcotic, that's what happens. You get pain.
Dilaudid, fentanyl, and he had his oxy at 10 o'clock.
Sean?
Nobody came. 12 6 hours.
Okay. When somebody is on, say, let's just say someone's on 10 of oxy every day, 3 times a day, and then they have surgery, you create new pain for them. That 10 of oxy 3 times a day is not enough. They need more.
Fentanyl, which is 10 times stronger.
You mean fentanyl that goes out of your body within a few minutes or an hour?
It still affects the receptors.
No, it doesn't. When was the last time he got fentanyl?
What about the Dilaudid he got?
Shot. Yeah, the Dilaudid is for the surgery pain, but he still needs his baseline oxycodone. Shot. Don't you think? I'll leave it up to you.
I think if he's sedated and sleepy, I think that we need to hold off on his medication, especially because he's had Tylenol.
I agree.
Going to the bathroom right now.
Is he?
I think we need to lay some eyes on him. Just wait. Just wait. Shot. All right. So this is really a good location right here. It's right where the pain nerve should be. But I'm not right on the bone yet. I'm still at the fascia. Shot? Yeah. So there is the last burn on the left side. It's a nice burn. I feel the bone. I feel the architecture of the bone. And I'll go to the other side. I'll just stay here. But I mean, I'm going to go to the right side at this point.
Can I have the towel, please?
And we did all 3 burns. Shot? Way too. That's interesting. How is that possible? Oh, man. That's not the midline. Luis,
No, I know.
who put that?
Me.
Yeah, listen to me. Listen to me. From now on,
Yeah.
do not use the x-ray to find the midline. Use your finger. Okay?
Yeah, no,
Yeah.
well, yeah, I feel now that's fine.
Yeah.
Yeah. No,
I'm
but
wondering,
these are
I'm
all
here.
legs, yeah, they're okay.
Give me some num-num.
Yeah. Well, this is where actually we.
Let me just do a little bit of num-num. Yeah, I would just use your finger going forward to find the midline. Because the x-ray can be wrong quite often. Remember, x-ray is 2-dimensional representation of something that's 3-dimensional. Shot. Shot. All right, that's pretty damn good. Let me just see. Hold on. Shot. Yeah.
Yes.
Let me see. Hold on. Shot. Gosh, that's perfect right there.
Blade.
All right, any questions from our audience?
Yes, we have a question from SPX730 on YouTube.
Hello, SPX 730.
They asked, are there any super small cameras yet to attach to the needle and see exactly where it goes? Or it wouldn't make any sense because you wouldn't see target tissue anyways?
Yeah, great question. I don't know if there are super small cams, but you need to use the X-ray because it's really, everything is localized based on the bone, the bony anatomy of the patient. So a small camera, you would just see blood and muscle. You really wouldn't see what you need to see to do the procedure, which is the X-ray. The X-ray gives us the point of contact where we need our target point. Okay, like right where I am right now. I think it would be interesting to see with the camera, but it wouldn't change how I did the surgery using the X-ray machine. Yeah. So I'm dancing around the facet joint, and what's interesting, shot, I'm on the TP, lateral, and I'm creeping medially, and I'm hitting right here. That's the exact spot I want to be. And so I'm going to paint this area with the bovie. All right, that's pretty good. Next we go down to the L5 TP, where you have the L4 dorsal ramus shot to medial shot. It's a little bit better. Any other questions?
No current questions.
So it's just a methodical process of shot. Yep, that's pretty damn good right there. That's as good as it gets. You just kind of march down and get all those nerves. There's 3 of them on each side that we have to get today for this patient. That obviously every patient's different. Shot. But the L4-5, L5-S1 are definitely the most common nerves you're going to have to treat. Facet joints you're going to have to treat. I actually feel the TP. I feel the mammillary process shot. A little bit north. I want to be right on it. Shot. I want to be a little more medial. Shot. That's perfect right there. I could feel the bone. You must feel the bone with your tip of your electrocautery unit. If you don't feel the bone, then you don't know where you are. And you need to be on the bone. You need to be really on the interface, right on the surface of the bone. That's where the nerve runs that you're targeting. So as long as you're on that surface of the bone where the nerve runs, you're going to get the nerve. And the nice thing about our procedure is you're able to kind of move the probe around into different areas to make sure you get it. With an RFA, the doctor just plants the probe. See, that's the perfect spot right there. See the tip? That's exactly where you want to be. I mean, literally perfect. The nice thing about this patient is he has really nice anatomy. He's got a nice physique, so there's not a lot of fat or deepness we have to get to. It's pretty straightforward. Shot. All right, so just about there, you guys can see that little valley. Shot. Right where the tip of the bipolar is, the bovie is, you can see the valley. I just can't feel it yet. There it is. I feel it now. And sometimes you have to push down. And the reason why you have to push down is that there's fascia. There's a membrane, a fibrous membrane above the spine that is catching my tool and pushing me backwards. So you got to fight it a little bit. Let's just see where that is. Hold on. And shot. Oh yeah, it's nice. I need to go more medial a little bit. There we go. That's better. Shot. I could feel the fascia release. Beautiful. And I'm literally dancing right where that bad nerve, that pain nerve would be. Let's just take one more picture. Shot. I want to go a little more medial. So I feel good. Hopefully that does it for this gentleman. But everything went very well. And are there any questions?
We have one question.
We'll take one question and then we'll end the broadcast. But this was a Deuk plasma rhizotomy bilateral L4-5, L5-S1.
And the question is, it comes from Teak on YouTube.
Hi there, Teak.
And they ask, is this the same tool you use when doing exposure during fusions?
Yes, it is. Great observation, Teak. It is a extended guarded bovie tip. Extended guarded bovie tip.
And that is it for questions.
All right. That's how I got the idea, Teak. I've been doing this for many years, and I realized, you know what? My fusion patients never have pain from their facets afterwards. And I realized why. All right, great job, everyone. We'll see you all, I don't know if Thursday, but definitely next week. Have a good night. Thanks, Henry. You can shut it down.